Good afternoon. My name's Emma Searle. I'm a consultant haematologist based at the Christie Hospital in Manchester, UK, and the University of Manchester. And I'm delighted to talk to you today about the exciting area of development in acute myeloid leukemia that is Menin inhibitors. So, as we're all aware, as practicing haematologists, relapsed acute myeloid leukemia remains an incredibly challenging condition. And we're constantly on the lookout for new developments that represent valid therapeutic options for this portion of patients. And in recent years, the big news in relapsed leukemia has to have been the menin inhibitors. And menin inhibitors work by disrupting the binding of menin to the KMT2A fusion protein, therefore disrupting this chromatin complex, leading to inhibition of aberrant leukemogenic transcription programs. And these agents, of which we now have a number, have been being evaluated in clinical trials both as monotherapy and in combination. And I'm sure many of you who are watching this video will be aware that the FDA has now approved revumenib for patients with relapsed leukemia used as monotherapy. So in terms of the monotherapy menin inhibitor trials that have data outputs, the overall response rates in terms of morphological leukemia-free state or better, are sitting roughly around the sort of 40 to 60% rate, depending on the agents, with a CR/CRh rate of around 25 to 45%. And obviously, there's no head-to-head comparison between these agents, and it's very difficult in terms of efficacy rates to really distinguish one agent from another. However, there's definitely differences in the toxicity profiles of these agents, and that makes a difference to how we might use these agents in the future in the relapse setting. So a class effect across all of the menin inhibitors is differentiation syndrome. I think, again, as practicing haematologists, we're used to managing differentiation syndrome, whether that's in the APML setting or as a result of giving IDH inhibitors in combination. But I think what we're seeing with the menin inhibitors is really very brisk and, potentially quite dangerous differentiation syndrome. I'd say that this is an entirely manageable side effect, but you just need good education and awareness as to how to pick up those events and how to manage them. And there have been recent How I Manage Differentiation Syndrome publications that can help guide that. But broadly speaking, the principles are looking out for fluid accumulation, looking out for signs of an inflammatory surge in a rising white cell count, and not being afraid to hold therapy, to give steroids, to give hydroxycarbamide, hydroxyurea, to bring that white cell count down, and really letting that settle down before you resume therapy. So that's the class effect across all of the menin inhibitors, but specific to some of the individual agents are issues around QTc prolongation that has to be monitored for. We see that reported with revumenib, but we don't see it reported, for example, with bleximenib or enzalutamide. And so there will be a difference in perhaps how you're needing to monitor patients depending on which agent you're seeing. So what's the longer term view for menin inhibitors? Well, obviously it's fantastic to have potentially relapsed options inside and outside trials for our patients with KMT2A rearrangements and NPM1 mutations, which has been the focus of the registrational studies with monotherapy menin inhibitors. But I think we're increasingly interested about the activity of these in other medically defined groups, such as the NUP98 patient population. And I think we're also increasingly interested in those patients who may be menin-like in their disease behaviour and who may also be amenable to a menin inhibitor approach. I think the other key areas for development moving forward will be using these drugs in the upfront setting. It's a kind of blanket rule in AML management that our best chance of getting a patient through to a sustainable cure is that first treatment, and the focus of much combination research is going to be around getting the best possible response with the safest approach that we can manage in the upfront setting. And there are studies now evaluating the use of menin inhibitors in combination with non-intensive regimes, such as venetoclax and azacitidine, but also intensive chemotherapy regimes, such as 7+3. And I wait to see the outcomes of all of those studies and randomized studies in that space in due course. And then I guess the final thing I'd like to say is I'm very interested in the efforts of Andrew White and the Intercept team in using these sorts of agents to intervene at the molecular persistence or molecular relapse state. So I think that may be very important in terms of improving outcomes in our frontline patients, and also very interested to see what roles menin inhibitors might have in the maintenance setting after allogeneic stem cell transplant. Again, really trying to maximize responses to frontline therapy to prevent having relapsed patients to manage in the first place. So I hope that's given you a useful summary of where we're up to with menin inhibitor research and where the future research directions may be leading us. Thank you for listening.